Okay, we are back. Hope everyone else has come back again. And we're going to continue with our symposium, and our next presentation is going to be co-presented. First, I want to introduce to you Dr. Lisa Zickuhr, and she is an assistant professor of medicine at Washington University in St. Louis School of Medicine. And she serves as the associate director for the rheumatology fellowship training program and the director of the medicine clerkship. Her scholarship focuses on medical education and has a special interest in teaching health equity and justice, as well as integrating clinical training into the virtual care environment. She received the Clinician Scholar Educator Award from the Rheumatology Research Foundation for her proposal entitled Best Practices for Sharing Decision-Making During Virtual Care Encounters. And she is also collaborating with many others, including her co-presenter, Joe Monroe, who I will introduce. And this collaborative effort is to develop an interactive module that teaches an approach for assessing cutaneous lupus across skin tones for graduate medical trainees. And so we are just so happy that Dr. Zickuhr has joined us this morning. This is a very exciting topic and something that we all can appreciate from our medical students and those in practice. And we want to hear all about it. Our co-presenter, Joe Monroe, has joined us from Tulsa, Oklahoma. And he is, if you don't know, he is the founder of the Society of Dermatology Physician Assistants, the SDPA Society. And so it is amazing that he has been in the game for such a long time. In 1992, he founded the Society of Dermatology Physician Assistants that is now has over 5,000 members, not only in the US, but in Europe. He is a graduate of the OU PA program, and he has expertise in dermatology and dermatologic surgery, and he has worked full-time in those arenas. He has been involved in teaching and writing hundreds of clinical articles, as well as textbook chapters, and continues to teach for PA school, medical residents, for OU, but also for Washington, Oregon, and Pacific universities. And he's put in here his age. He's currently at the age of 80. You would not ever think. He's taking on a new challenge, and he is now employed with the Oklahoma City VA as one who is performing teledermatology in this day and age. And so we are just so happy that both of you all have come together as co-collaborators and co-presenters. And we want to hear this wonderful lecture that you have for us today entitled Lupus in Skin of Color. Thank you so much.
Thank you for that great introduction. I'm going to share our slides here. Get our presentation up and running. Okay, so thank you so much for that introduction. Sorry about that. There we go. Okay, and as mentioned, Joe and I are really thrilled to be here. I am humbled personally, as a rheumatologist, I'm always so grateful to have amazing dermatologists to collaborate with to treat patients effectively. That I come from the side of medicine. Oh, there's a rash. I'm not that good at rashes. I'm so lucky to have people to work with who really are like Joe and all of you here today. So we are going to talk about cutaneous lupus across skin tones. I do have a financial disclosure. I consulted on some educational material development for Eli Lilly in the realm under the domain of lupus. And Joe's financial disclosure.
Dr. Zickuhr,
Yes.
can you put that in duplicate display mode?
Oh, I apologize. Here we go. How about that? Thank you for letting me know that that was wrong.
There you go. Thank you.
All right. So we know that there's a gap in teaching, and that there are educational challenges with training physicians and clinicians to address cutaneous lupus in all skin tones, as well as linking the manifestations of certain skin manifestations with systemic disease and serologic studies. And so we're going to go through a little bit of all of that today. It'll hopefully be informative. And so we hope that by the end of the session, you're able to recognize forms of cutaneous lupus across skin tones, categorize the pattern and with the serologic profile, and associate that with relative risk of systemic disease, and possibly even treat your patients with cutaneous lupus. And here we go. So there are a lot of abbreviations we're going to use. Hopefully most of these are familiar, ANA and ENA, and then the various forms of CLE as well as SLE to distinguish cutaneous from systemic manifestations. So why is this topic important? Well, first of all, CLE overlaps with systemic disease, and oftentimes it can be a clue to diagnosing this mystery syndrome that's causing a lot of different manifestations. Different types of CLE overlap with systemic disease more often, acute cutaneous lupus being the most common, and being able to recognize cutaneous forms really can help cinch a diagnosis. The timing of if cutaneous and systemic disease are going to overlap is different in different patients. Sometimes patients present with a rash and then they later go on to develop systemic manifestations. Sometimes they have rip-roaring systemic disease and they later go on to develop CLE. And sometimes they both present at the same time. And so keeping this in the back of your mind when you are approaching said patients is really important. This is especially important because there's this concept of if we can make a diagnosis, intervene and treat early, we can avoid long-term damage. And this is in any organ system, including the skin. Patients who identify as an underrepresented minority are at increased risk of having long-term damage either from cutaneous disease or from systemic manifestations compared to their white counterparts. This is one study that looked at Class E damage score in patients with all forms of cutaneous lupus and strategized scores based on an initial evaluation and then subsequent evaluation, and categorized them by different racial ethnicities. And you can see how there is the significantly higher damage score among patients who identify as Black or African American compared to those who are white or fair skinned. Furthermore, there's been a lot of literature published recently about how medical education materials underrepresent patients with skin of color in the images presented in those materials. And that translates into impaired clinical confidence in the patient care environment. So we surveyed about 150 internists, rheumatologists, and dermatologists in the St. Louis area, asked them how confident they were diagnosing various rashes and lupus-related rashes. And they rated this on a scale of 1 to 4, 1 being not at all confident and 4 being extremely confident. And you can see that overall providers have moderate confidence with any rash. And then when you add lupus to the mix, that decreases a little bit. And then if you have lupus in a patient with skin of color, that is the greatest decline in confidence, which really is a shame because, as we've just talked about, patients with skin of color and who identify as an underrepresented minority suffer the greatest burden of disease. And so they deserve to have physicians and clinicians who are comfortable, confident, and competent, recognizing their condition, diagnosing their disease, and then initiating appropriate treatment. So by the end of today's talk, we hope that you are able to recognize subacute and chronic cutaneous lupus, examine the patterns of these and correlate with the serologic profile, and then treat the conditions, as we've already said. But because of time, we're not going to cover acute cutaneous lupus or other variants of chronic cutaneous lupus beyond discoid. So I'm going to hand the baton over to my colleague, Joe.
Thank you, Lisa. And you can proceed to the next slide if you would. Discoid lupus is by far the most common form of cutaneous lupus. It typically appears above the neck, but can be generalized. I should add, for those of you who have matriculated through primary care, you probably noticed that it usually gets called fungal infection at some level. Next. There are 5 forms of DLE, and I promise not to read every stinking word of this. As you can see, there's a localized version, which we see a lot of. I don't see much generalized, and I don't see much hypertrophic. I know they exist. I'm aware of it. I have seen lupus profundus. That's rare in my experience. I have never seen childhood variant, but it is notable that the childhood variant of discoid lupus is less about photosensitivity and female predilection. Systemic lupus with the childhood variant may develop later. Next slide. Why do we talk about skin of color? What's the relevance? Because 40% of discoid lupus occurs in those with skin of color. And because discoid lupus can present so many different ways on skin of color. Next. Now, I just said we're going to talk about skin of color. This person has a color just like mine, which is none. You got to have somebody with none. She's actually like a skin type 1.5. And you can see that for 25 years, she suffered with this and was misdiagnosed with all sorts of things, including eczema, fungal infection. Fungus has got to be thrown in there eventually by somebody. Psoriasis, and finally somebody thought enough to biopsy, and that somebody was me. No brilliance involved. It's just what derms do. When in doubt, we cut it out. I treated her with topical steroids, hydroxychloroquine, and sunscreen. Which probably none of which is going to work, probably because she does yard work for a living and did not want, care to wear a hat and did not care to protect herself, but we can do what we can do. Next slide. This is a little more classic discoid lupus in a so-called white patient, although you can see this is like a good strong skin type 3, 3.5, if there were such a thing, darker skin. And these lesions are more typical. Annular configuration with atrophic centers, scaly active borders, and often hypopigmentation in white people. Chronic sun exposure is the key factor. It's not the only factor, but is the major factor. So loss of pigment can happen in either. Yes, next, please. This young lady was a nurse who came to see me, and for every year in the summertime, this would flare up in this area. And she'd been treated with the usual and customary products for a whole variety of diagnoses. And I just did what I do best, which is take a piece of skin, send it in. And I was rather suspicious of discoid lupus. She did respond to topical steroids and sunscreen, given how small an area. And she was so grateful to have a diagnosis. She was perfectly willing to wear a hat, stay out of the sun. So she got better practically overnight. Next. Now, this is the only slide in this presentation of mine that's not my photo. I can't even remember where I got it, but it illustrates a point that enlarged follicular ostia are highly suggestive of discoid lupus. They're not pathognomonic, but they're suggestive. And often the keratotic overlying skin, hyperkeratotic skin, will penetrate down into those enlarged ostia. And when you lift up that edge, you see what some people have called tax hyperkeratotic spikes, which are pathognomonic for lupus. And often this form of just a scaly patch with erythema will be how discoid lupus presents. Next. This is more typical of what we're driving at today. This is discoid lupus in a person who obviously skin type, I would call this skin type 4. Discoid lupus can cause in these people hypo or hyperpigmentation, and of course permanent scarring. And I think you can see that it's quite likely this gentleman will have permanent scarring. He was misdiagnosed for months and months and months and had a job that took him outside. And so we treated him with hydroxychloroquine, in the beginning, a little bit of steroids, and I did some intralesional steroids on a couple of those gnarly lesions that you see there. And with the hydroxychloroquine and getting out of the sun, he got better in a hurry, but he still was left with scars and loss of pigment. Next. This is a little more typical. If you had to typify discoid lupus in people with skin of color, this is what you're going to see. And it's often a little bitty thing. Sometimes it'll be like a nip on an ear and a little beady erythematous raised margin. In the center, if you could get down and look at that a little more carefully, you could see there'll be enlarged pores, enlarged follicular ostia. This person did not have systemic lupus, only discoid lupus, but was very disturbed. And we were able to treat her with a combination of topical steroids, hydroxychloroquine, and sunscreen. Next. This is what we call, a little bit sarcastically, we call it burnout discoid lupus. This patient didn't even come see me for this. I don't remember what he came for, but I looked at this and said, what the heck? And we got a story from him, and he never did tell me, but I figured out eventually that it had been long since gone discoid lupus, which we term burnt out. You can see there's residual pigment around the margin, loss of hair, and tremendous and permanent loss of pigment. That's fairly typical. We won't see a lot of those, but you do see them. Next. Risk factors for DLE include just being a woman, being a non-Latino Black, smoking. Smoking not only predisposes, but makes treatment more difficult, as it does for a lot of things. But of all the exacerbating factors, ultraviolet exposure is the most significant in this part of the country. We have that, a lot of that. I practiced for 20 years in the Pacific Northwest. I didn't see that much DLE up there, but we certainly see it down here. There's also a proven genetic basis. In this part of the country here, we have a lot of Native Americans who are predisposed to this. Next. This is an interesting presentation. The parent brought the kid in and couldn't figure out what was going on. She thought it was dirt, and I assured her it was not. And if you could get down and look at this, if I'd taken a better photograph, if you look at the upper outer quadrant, you can see enlarged follicular ostia, hyperpigmentation. She was seronegative for systemic lupus, but there was a family history of systemic lupus. So to have it isolated in the ear like this is not terribly unusual. Next. Now, this is an unusual presentation for discoid lupus. Everybody, quite understandably, had treated it with antifungal topicals and oral medications for months and could not understand why it wouldn't respond. Nobody had ever scraped it, nobody had ever cultured it, and nobody had ever biopsied. All I did was biopsy and found some key findings such as interface dermatitis, which by itself would not indicate lupus, but along with some other features did approve the diagnosis. She did not have systemic lupus, and she did not have ringworm, which is what it gets called here. Okay, next. This woman, again, is Native American. She had these fairly firm nodules on her skin. They were on the other side as well, and she had been treated for all sorts of things. She was self-identified as Native American, and she does, as you can see, have skin type 3.5 or 4, if there were a half. The diagnostic keys were the Native American history and her being female. But I did not know that it was tumid lupus, but this is what this gets called. I did prove that diagnosis with a biopsy. I did a punch biopsy deep into one of these and saw that I didn't see, but the pathologist saw the typical features and told me, and I was able to treat her with sunscreen and hydroxychloroquine. Next. Last but not least, it's not one you'll see very often. This slide is full of content. If you see, for one thing, when I saw him, the first thing I saw was that nodule over on the right vermilion lip on the mucosal surface. I thought it would be a squamous cell carcinoma. It was not. It turned out to be lupus. All of it was lupus. And he also turned out to be on phenytoin, which might account for the gingival overgrowth, which you also see, which I was wondering about. That had nothing to do with the lupus, but you can see he's a sun-bitten guy, and again, sunscreen and hydroxychloroquine fixed him right up in that area. Next. All right, Lisa, it's yours.
Yeah, I get the honor of being able to talk a little bit about when to be concerned about systemic disease in someone who presents with discoid. So most patients who have discoid lupus, it's merely confined to the skin, and they actually don't have systemic disease. Only depending on which cohort you look at, the numbers vary, but about 20% of patients with discoid at one time or another may have systemic manifestations. And the timing is really important, because as we talked about before, it can happen. You can get the skin first, you can get the systemic disease first, you can get both at the same time. But for those patients whom you will encounter first, meaning they first present with discoid lesions, usually if they're going to go on to progress to systemic lupus, that'll happen within the first 5 years of diagnosis. There's some cohorts that say up to 10, but really the first 5 years are the most critical in terms of keeping an ear and an eye out for systemic manifestations. There are some clinical clues that can give you a nudge or a hint or an indication if someone with discoid is going to present with systemic disease. This study was published in 2011, a while ago, but did a really elegant job of looking at multiple cohorts and multiple case control studies and bringing them together in a really elegant way. So they looked at people with just lupus, they looked at people with just discoid, and then they looked at people with both. And A in this instance are people with lupus, B are people with discoid, and then the Venn diagram overlap with those with both. And what they found is that in terms of clinical manifestations, people with systemic disease tend to have more serious and involved manifestations. So they're more likely to have lupus nephritis. They also are more likely to have dry mouth and photosensitivity. In terms of clinical manifestations, those with both discoid and lupus can get generalized discoid lupus. They tend to have more joint symptoms, especially arthralgias, inflammatory arthralgias, and then nail changes, specifically periungual telangiectasias. And I will show you examples of each of those in the coming slides. People with discoid who don't have systemic disease don't have any of the systemic manifestations. And so that's why this part of the Venn diagram is empty. Those with, in terms of looking at labs, to use that as a stratification mechanism, those with systemic lupus, they have a lot more positive antibodies. Lupus loves to make antibodies to everything. And so if you start ordering ANAs and ENAs and other things, and it's all lighting up positive, that's probably a good indicator about systemic disease, especially the anti-double-stranded DNA. As far as overlap, there tends to be mild, not very mild and not at all necessarily severe CBC abnormalities in terms of anemia, low white count. They'll have a positive ANA because anybody with lupus can have a positive ANA, and those with discoid can also have one, and then tend to have more of a elevated ESR. So going through the clinical indicators of what can possibly signal when to be concerned about systemic disease. Generalized discoid is one example. This is one of my patients. He has discoid lesions all over his body. And so generalized discoid lupus will present both in the head, the neck, and below. This is a great example of burnt out discoid that Joe just taught us about. So it doesn't have that erythematous collarette. Instead, it's a more subdued collarette of hyperpigmentation with central scar and hypopigmentation within that. So in this patient, actually, he ended up having systemic lupus, saw the discoid on the trunk, and ordered a full workup, and he did have systemic disease. The other part is patients with both discoid and systemic lupus tend to have inflammatory arthralgias. So what does that mean? You ask, any joint pain? They say yes, but then you got to dig a little bit deeper. And so these arthralgias are the type of joint pain that hurt more in the morning, get better with activity. they feel better at the end of the day, have some morning stiffness that lasts longer than an hour. And then you go look at their hands and they look totally normal. And you're like, what is going on? So if it sounds inflammatory, but there's nothing on exam, it could still be related to an underlying inflammatory condition. These are examples of periungual telangiectasias in different skin tones. This isn't the best example. You can actually see that this is dermatomyositis with the Gottron's papules here. But I thought it really did a wonderful and beautiful job of showing these periungual telangiectasias in 2 different skin tones. And I have to be honest, the fact that I couldn't find a representative picture of somebody with lupus having this speaks volumes. In my personal experience, I see this more often in patients with scleroderma and with dermatomyositis. I have seen it in lupus, but it's not as common as with some of the other conditions. All right, Joe, you want to teach us about subacute?
Yes, carry on with the slides. Yeah. Subacute cutaneous lupus occurs mostly in patients who identify as white. And I say that because we're supposed to be talking about people with skin of color. But in this particular one, it presents as a papulosquamous rash, which presents with bizarre annular patterns, which may evolve over time. These patients are extremely photosensitive. Next. The difference between these two you can see, and that is with the scaling present in the patient on the right, contrasting with the interface dermatitis, which appears dusky and violaceous in darker skin tones with the patient on the left. So darker skin tones do make a difference in terms of how it presents. Next. This illustrates the same thing, although you can see a lot more inflammation on the chest, and you can imagine that this patient of color on the right is not only going to have a lot of inflammation, but a lot of scarring and could well develop keloidal formation. Next. Now, you know, in your heart of hearts, those of you who have matriculated through primary care, or maybe you're still in it, you know that both of these are going to get called fungal, and somebody will find it irresistible to throw antifungals at it. But we urge primary care people to stop and take a breath before you do that and think about the differential, which does include such things as subacute cutaneous lupus. And you can see the difference. The person on the right, in the picture on the right, is a little bit darker color. The erythematous leading edge on the patient on the right helps to differentiate from tinea corpus. If you can look carefully, you can see that this scaling on the patient on the right is on the trailing edge and not on the advancing edge. I still would KOH this to make sure it's not fungal, but just on the basis of that trailing edge. And there are other conditions like pityriasis rosea where there is scale on the trailing edge, but it's very typical of subacute cutaneous lupus. Next. Love that nail polish. Can you go back to the last slide? Love that nail polish there. It must be an OSU on that little finger. Anyway, next. So you can see the patient on the left has skin type 2 probably at most, and you can see how they present differently. The erythematous leading edge differentiates it from tinea corpus. These are impressive rashes though. So, and you can see how the patient on the right with skin type 4, good strong skin type 4, has lost pigment, has some hyperpigmentation, but has a lot more areas where they've lost it. Next. And different skin tones can look different in other ways too. The person on the left, I came in and saw that, and I'm like, my God, what is that? I was thinking all sorts of things until I biopsied the person on the right. Again, we're seeing the scaling and erythema on the leading edge, which again differentiates it from the putative tinea corpus. But these can be tricky. You just have to be ready to biopsy. Next. And back to Dr. Lisa.
So thanks, Joe. We hope that showed a nice array of subacute cutaneous lupus in different skin tones, since most that occurs clinically, it does happen in lighter skin tones to help train the eye to recognize the subtle nuances in that presentation. So in terms of the relationship between SCLE and systemic disease, it's greater than what we see in discoid lupus. So instead of only 20% of people with discoid having systemic manifestations, about half to 2/3 of patients with subacute will develop systemic manifestations. The first is, we've talked about the racial and ethnic differences of SCLE predilecting for patients who identify as Caucasian and white, but systemic disease is the opposite. People who identify as Black and Hispanic and Asian, they actually get more severe disease than those who identify as white. So there is a racial difference between SCLE and systemic disease. This table I'm showing on the left is a case-controlled cohort study, and since it's case-controlled, you're not going to see the differences in race and ethnicity. But what this study does highlight in particular is the extreme photosensitivity of SCLE and how the majority of patients that presented with SCLE and more so than those with systemic disease reported photosensitivity. The other aspect that I think is really helpful is to look at the serologic profile. So a lot of rheumatologists, they may say, oh, you don't really need antibodies. You're just going to treat the clinical manifestations anyway. I actually really like serologic studies because it can help classify patients, and then it can also give you an idea of what their disease course is going to look like. And so this is a perfect example of how SCLE can be associated with anti-Rho, which is also called SSA, and anti-LA, which is also called SSB. And systemic lupus can also have that, but systemic lupus is going to be more greatly associated with anti-double-stranded, anti-Smith, and anti-RNP antibodies. So as far as symptoms go, much like discoid, where patients with both lupus, systemic lupus and discoid lupus had more milder manifestations, that happens also with subacute. So this bar graph shows one cohort of patients with SCLE and then patients with systemic disease alone, and they parsed apart the different manifestations and looked at the prevalence of them in the two groups. And what we see is that those with systemic disease are more likely to have renal, lupus nephritis, more likely to have significant hematologic manifestations. And then similarly to what we showed prior, those with SCLE are more likely to have photosensitivity. So in a way, when I see patients with SCLE or discoid lupus, I kind of think, oh, okay, this may end up working well for the patient because it's almost like those cutaneous manifestations in terms of statistics protect against the really severe forms of systemic lupus. Drug-induced SCLE is also always something to keep in the back of your mind. I got burned with this. I had a patient that I treated everything to get his SCLE under control, and I was so unsuccessful. And then I was like, oh, let's look at the med list, and hello, calcium channel blocker, and stopped it, and things cleared up pretty quickly. So there are different agents that are more or less implicated in drug-induced SCLE, and there's a bar chart for you. The most common ones that I encounter are the proton pump inhibitors and the calcium channel blockers. And actually, in a recent survey of a tertiary dermatology care center, a third of patients with SCLE actually ended up having drug-induced. So each of these agents has a different risk profile for causing SCLE, but as I mentioned, just based on prevalence of use, the ones that I've most encountered are proton pump inhibitors and calcium channel blockers. So we wanted to take a moment to talk a little bit about the ANA and the ENA. So maybe you're seeing a patient in clinic and you recognize some of these clinical signs that could link to systemic disease. So what do? Well, you order an ANA and ENA, and how do you interpret that? So the first that I would like to share with you is that we've all heard this throughout all of the training. ANA is sensitive but not specific. And why is that? Well, it's because this antibody occurs naturally. So we all have natural cell death. And when that happens, cells undergo apoptosis and extrude their nuclear contents, and then antibodies form to those contents, anti-nuclear antibodies, which then help clear all of that cellular debris. So having an ANA doesn't necessarily mean that you have an autoimmune disease, or even more specifically lupus. It could just be your body's natural progression of clearing up cellular debris. The other part of this is of its non-specificity is that an ANA goes along with many different autoimmune diseases. I think one of the common misconceptions is that ANA equals the lupus antibody. And that's not entirely true. You can have, I love this table from UpToDate. It's table 1 if you type in positive ANA. I use this for teaching all the time, but tons of different autoimmune conditions can present with an ANA, including inflammatory bowel disease, different chronic infections, malignancies, so on and so forth. And so when I see an ANA, I think in my mind possible autoimmunity rather than lupus. And that helps me keep a broader spectrum in terms of my approach to evaluating. The third concept is that the titer matters. So the higher the titer, the more likely you are to have autoimmune disease. And this was, how they report out the titers was actually based on several population studies. So the lab medicine specialists, they looked and they saw, well, people that had an ANA titer of 1 to 160 or greater, only 5% of those people did not have an autoimmune disease. So those with low titers are more likely to have a positive ANA and not have any underlying autoimmune condition. So if you flip that on its head and think about that in the converse, that means that the higher the titer, the more likely you are to actually be having a patient with a condition and the positive ANA. The fact of the matter is that several factors can influence ANA positivity. Age, so the longer you've been alive, the more cell death you've had and the more opportunities you've had to develop a positive ANA. Similarly with malignancy, there's a lot of cell death and cell turnover that happens in cancers. So a lot of more apoptosis. Certain medications can induce ANA. I think we're all familiar with anti-TNF inhibitors and how that can even also induce positive double-stranded, but doesn't necessarily mean that you have lupus. And then family history. If you have somebody in your family with a history of an autoimmune disease, you are more likely to have a positive ANA, but doesn't necessarily mean that you have an underlying condition. Another complicating wrinkle is that timing matters. So in all autoimmune conditions, we have this continuum of disease where individuals are susceptible. Maybe they have a genetic predisposition. There's something in their environment that predisposes them to developing an autoimmune condition. And these things collide and trigger the production of autoantibodies, in this case, perhaps an ANA. And that ANA can just stay there and do nothing, or maybe at some point the ANA actually starts to become a problem and start to develop symptoms that are kind of nonspecific, but don't really sound like, slam dunk diagnosis until things progress and then become full-fledged lupus. And so it can be really tricky sometimes to figure out where people are on this continuum. So I use a lot of I think and I'm not sure, and it's possible when I'm explaining this to patients, which can be really frustrating to patients because sometimes they just want an answer, and that's not always possible in our world. So how do you use these lab tests to diagnose systemic lupus if that's what you're worried about? Well, first is order an ANA only if you suspect that there's an underlying autoimmune rheumatic disease. So history, physical exam, and y'all see patients so fast, like in and out. Our review of systems takes like an hour. And so always happy to help and provide that service for you. But when you're approaching that history, just keeping in mind that there's a lot of other autoimmune conditions, not just lupus. And so questioning should hopefully include features of all those other diseases. The second is interpreting the ANA in the clinical context. So I don't think I ever understood sensitivity and specificity until I went through rheumatology fellowship and I had to interpret the ANA. And I'm going to try and provide a visual representation of what goes on in my mind when I'm thinking through a positive ANA in the clinical context, and hopefully provide some clarity of how we do this in rheumatology. So The first is you have some sort of pretest probability based on history, physical, and your clinical gestalt. Then you order an ANA and it comes back with a result, and you interpret that within the patient population that your individual patient represents. And then you put all that together to somehow converge in clinical decision making. I'm going to give you some examples. So let's say you see a patient with leukopenia, you get a UA and they've got a lot of blood in their urine, and they have a malar rash that looks like acute cutaneous lupus. That sounds like a slam dunk to me. That's got like a lot of features that sound like systemic disease. Check an ANA. Oh, and it's super high titer. And this patient represents a patient population of a young female who identifies as Black or African American. That's all really high risk. And so your likelihood ratio of that patient having lupus is pretty high based on that ANA result. Then you connect the dots in this Fagan nomogram, and it's off the charts post-test probability that this is likely lupus. And so this person would clearly be diagnosed with systemic disease. However, there's nuances. I just showed you a really easy one, but what if you saw somebody with discoid lupus and they were complaining, and on you're chatting with them, and yeah, they have back pain and they're fatigue, but the labs are normal. Well, I have to say, having discoid can put you at risk of having systemic disease. Fatigue, that's a non-specific symptom, but it can be associated. Lupus never affects the back, so that's helpful. So back pain probably isn't related, and the fact that all the basic labs are normal. You order an ANA, and it's 1 to 160, so right at that cusp of that cusp of teetering on the edge of really positive and concerning, and this patient is younger and identifies as Black or African American, and is a female. And so, the positive ANA has some enhanced likelihood ratio, but maybe not nearly as much as the patient I presented on the previous slide. So you put all this together, and there's about a 10% chance that you kind of come up with that this patient could have systemic lupus. And so, putting all the pieces together, I would say that this patient likely does not have systemic disease and would be somebody that I would encourage to come back and see me in 12 to 18 months because of that continuum I showed you, and how disease and symptoms can manifest over time and not knowing where she falls in that timeline. So as soon as an ANA is positive, step 3 is to always check the ENA. The ENA is so important because if an ANA tells you that there's an antibody against the nucleus, the ENA tells you which specific antibody against the nucleus is present. And they all have a phenotype and a prognostic effect in terms of the symptoms and the manifestations to suspect. And so if an ANA is positive, reflex should be to order the ENA to not only confirm positivity of the ANA, but also to provide supplementary information of the clinical spectrum. So not only is it associated with the disease, but also with disease prognosis and specific manifestations. You want to take us home, Joe? Oh, you're on mute, Joe.
I was blowing my nose a while ago, and I want to be sure. The key points are these: cutaneous lupus may occur independently or coexist with systemic lupus. When with subacute cutaneous and chronic cutaneous lupus, discoid variant coexists with systemic lupus. Systemic manifestations are often mild, including arthralgia, cytopenias. The discoid variant of chronic cutaneous lupus occurs with high frequency among patients with skin of color. And that's probably the biggest take-home message. If you didn't hear anything else today, get that, because you got to think about that, and particularly in females, and can be disfiguring, as we saw. Subacute cutaneous lupus most often occurs among patients who identify as white, highlighting the importance of clinicians training their eye to recognize interface dermatitis in patients with skin of color. Photoprotection is an important facet of treatment for cutaneous lupus erythematosus. And I want to, if I might, I saw a question come across the screen, and I should have touched on that in the lecture, didn't do it. Somebody asked early on, a few minutes ago, what kind of biopsy do you do on these skin biopsy when you suspect it? And the answer is normally you just do a shave biopsy and you don't have to do a punch. In fact, you probably wouldn't. You'd want to do a longitudinal shave, keeping in mind about scarring and location and so on, and informed consent. With the woman I had who had the tumid lupus, the nodules, a punch, because I want to assess all the way down into adipose tissue, because there are other things in the differential, including sarcoidosis, that we might miss with a shave biopsy. Anyway, I'm through now.
And that's the end. We're open for questions.
All right, thank you both so much, Dr. Zickuhr and Joe Monroe. I really appreciate it. We learned a lot from that lupus talk. It's very important for us to see lupus in patients of color, so I really appreciate the pictures that y'all provided. We do have another question from Sucharita Bowers. Has there been any increase in ANA seen secondary to COVID-19?
I have to say, I don't have a good answer for that. I feel like there's a lot of ANAs that get checked all the time. And so I can't say if specifically if there's even been a further rise since COVID-19 has come out. That's probably our bread and butter referral. Positive ANA, please evaluate. And so we see that really routinely in rheumatology, and are happy to help mental gymnastics of going through weeding through the details and trying to decide if it's clinically relevant.
Mm-hmm. And one more from Dr. Levine. For cutaneous manifestations not responding to antimalarials, what is your next best go-to agent?
You want to take a stab, Joe? I can.
Yeah, well, I'll take a lesson from you, because you mentioned, well, when you had a case like that, and one of the things you want to consider is what else is involved. Is it drug caused? And you want to review those things. Among those would be, I find, and for those dermatology types in the audience, and I know there are a number, think about minocycline. And I've been fooled by that a number of times. Teenage girls coming in sick and nobody can figure out why. And I don't want to pick on minocycline because I happen to like that drug, but it does have its downsides. So that's the sum total of my wisdom on that question.
So for me, when hydroxychloroquine, it's like, bummer, hydroxychloroquine didn't come to the rescue this time. I have a couple of possibilities in my mind. For discoid, depending, if it's not very severe, it's not very disfiguring, it's not generalized, I will try methotrexate. Sometimes I can I've had some success with some patients being able to be getting good control of their cutaneous lesions with a combination of hydroxychloroquine and methotrexate. The biggest bomb is mycophenolate. And so that has honestly the best data behind it in terms of all varieties of cutaneous lupus, acute, subacute, or chronic. And so, if something is more severe and I think it warrants going straight to mycophenolate, or if they have systemic manifestations that would warrant mycophenolate, I have a low threshold for pulling that trigger. I had an even lower threshold for starting mycophenolate before COVID. But in the literature of the care of patients with autoimmune diseases, there's been a lot of research done about the differences in response to COVID vaccine, and mycophenolate it really blocks the efficacy of COVID vaccine. So nowadays I am a little bit more reluctant to start it just so willy-nilly as I did before, instead thinking about COVID and things like because I've had patients die. I mean, they got vaccinated. It's just that the medicines they were on really didn't allow the vaccine to work, and so they got COVID and they died. So it's a real thing in our world. If mycophenolate doesn't work, then if it's discoid, then I have a wonderful dermatologist with whom I partner in St. Louis, and We often
I think
share
she's
the,
frozen.
am I back?
You're back.
Okay, where did I leave off?
If mycophenolate doesn't work.
Oh, if mycophenolate doesn't work, then and it's discoid lupus, I have a wonderful colleague in dermatology in the St. Louis area. And together we will share decision-making on whether to proceed with thalidomide. That is a miracle. So the patient I showed you with the picture I showed you of the generalized discoid, he was, oh my God, it hurt. I hurt looking at his rash. It was just so disfiguring and so inflamed and so painful. Poor guy couldn't even breathe without having pain because of his skin. And we tried everything and then finally put him on thalidomide and it cleared it up. In subacute cutaneous lupus, you can use thalidomide. There's not as much data. I've tried other things like there's some data to support baricitinib, one of the JAK inhibitors. That's the one that has there was a phase 2 trial in the Lancet a couple of years ago. I've had mixed success with that. And then I've even tried rituximab with mixed success. You can try Benlysta. Theoretically, that's supposed to help belimumab. And but I usually go down the route of the DMARDs before pulling out the other biologics.
Thank you. We have a couple more questions. So from Aaron Dwan, he's asking for DLE patients with a negative initial workup for SLE. Do you perform any annual screening for progression to SLE in the absence of any significant positives on the review system, such as an annual UA?
That's a wonderful question. I personally, that type of patient, I personally would not see back in my clinic. Instead, I would recommend to their primary care doctor that they needed basic labs once a year, CBC, CMP, UA. And then I would also counsel that patient, these are the things that you need to keep an eye out for. And if you develop any of them, please let me know and we'll reevaluate at that time. Joe, how about you? What do you do?
I totally agree with what you just said. Yeah.
Great. And then do you happen to know what percentage of patients with DLE and SCLE have a negative ANA?
No, I don't off the top of my head. I would have to look that up. And I imagine it would also change by cohort depending upon the ethnic makeup of the studied cohort. So sorry, that's something I
No problem. You can, we're happy to get in touch with you afterwards as well. I think your email was on the presentation. Is that right?
I believe so.
Okay, great. And then Dr. McLaughlin asks, would you mind speaking to the best test to order to screen for ANA? Do you use IFA by HEP2?
Yes, so there are two forms of ANA. One is an ELISA test. One is the indirect immunofluorescence that uses the HEP2 cells that Dr. McLaughlin has mentioned. The gold standard is the indirect immunofluorescence. And so that's my go-to. Guidelines, so Choosing Wisely campaign guidelines would say with the ELISA because it's even more sensitive than the immunofluorescence. And then if that's positive, move to the HEP2 cells. I honestly just, I pass go. I don't collect those $200 and I go straight to the IFA. But that may be a little bit of bias from my perspective because by the time people are coming to me, they have some symptoms that are warranting the test and are raising their pretest likelihood of autoimmune disease.
Right, that makes sense. One more from Dr. Harrell. We actually have a couple more. Sorry. Can you briefly touch on the sensitivity of a positive lupus band test on lesional skin of SCLE and the probability of developing SLE?
Yes. So there are some data, and positive band test is actually protective against developing systemic disease, based on the limited amount of data that are available in regard to the lupus band test.
Okay, great. And a follow-up to that one, do you typically recommend doing a sun protected? No, you don't. You're shaking your head.
No,
Okay.
Based on systemic symptoms. If they're there, we treat them. If not, it's okay.
Dr. Gower asked, do you ever attempt to taper hydroxychloroquine for patients with DLE? And how do you decide when the best time is to do that?
Joe, do you want to go first?
Yeah, first of all, I don't worry about hydroxychloroquine the way they used to. When I was in training, we worried ourselves sick over the ophthalmologic side effects, which are nothing to sneeze at, but they're not as serious as we once thought. So you just have to be guided by the patient's adherence to our instructions to stay out of the sun. My experience is that people come in and have the worst cases are going to go right back out in the sun and not pay much attention to, or at least, and you kind of have to keep them on it. And if I have to keep them on it, I don't lose much sleep over that. I do have them have their eyes checked once a year, at least. Some people say twice a year. That's my only caveat.
I agree with Joe. The few patients, so usually the patients just stop it and we never really get to talk about tapering. They just kind of stop it on their own, and most often it recurs. So I have never gotten to that point. However, my rule of thumb is this: with any autoimmune disease, if someone is stable for 2+ years, that means like not even a whiff of a flare, I will talk, like, and patients want to taper, I am on board for a trial. There's no guarantee that it's not going to come back. In fact, most of these conditions are chronic and they do recur. And so having that conversation with the patient is really important before making the decision. But usually they stop it on their own.
Okay. I think that may be the conclusion of our question. So I'm going to hand it over to Dr. Allen.
Wonderful. Thank you both so much. You did an awesome job. And just another review of these diseases that we see on a regular basis. Thank you both.